Looks like people are joining in now.
You got some great lipstick on.
Oh, that's recording, Emma. Welcome, everybody. As everybody's joining in, talofa lava, whakalawhala hiatu ni sampula, kia orana, i orana, and really warm Pacific greetings to you all. It's Tuvalu Language Week this week. Talofa lava. Ropiti, I forgot to ask you to please say a statement in Tuvalu, and but never mind, we'll try and find one as we go along. Yeah, so we'll just give the candidates or the participants a little bit of time to join in, and just to let you know that this session will be recorded. Emma, just to, I think we did let the people know it's 7 p.m. New Zealand time, but people may not have realized that we have changed our time since daylight saving.
There's been a bit of that this week for sure. On several meetings.
Yeah, I think our clocks went forward, didn't it?
They did. So
we lost 1 hour. So what used to be, you know, the same time previously, it's going to be 1 hour ahead. So we'll be doing this a little bit earlier, but that's all right because this is going to be recorded. So usually, just to let everybody know, this is the webinars are organized by the Pacific Society of Reproductive Health, so we can help and do some CPD for our Pacific SMOs and also registrars. But a lot of the time, a lot of our other colleagues do join in. I would like to take this opportunity to thank Emma Parry for agreeing to do the session on ultrasound, obstetrics, and gynecology for us this evening. Yeah, you've got Emma is a colleague of mine and also a very good friend. And as you can see when we did the advertisement, everybody, that you've got her profile listed there, but I'm not going to read it because it's really long. But I'm really proud of you, Emma, for what you've done and what you've achieved and all the and all the work that you have been doing. I think what I might do is that I might give it over to you if there's something else that you would like to, like to say about yourself. But before we do that, I'll ask Roberti to start with a word of prayer. Thank you, Roberti.
Okay, let's pray. Heavenly Father, we want to thank you and bless you and honor you for this privilege to have this education session through this excellent communication of Zoom webinar. Lord, we commit our session to you and especially our speaker. Thank you so much for Dr. Emma Parry for her time and availability and also her expertise, Lord God, in ultrasound, and pray, oh God, for your blessing upon her, your blessing upon the panels, and especially the participants in our Pacific region. Pray for your blessing upon them. May we have a really good session, and thank you so much for your blessing upon all of us. In Jesus' name we pray. Amen.
Amen.
Thank you. So Emma, I'll just to let the participants know I'm on night shift tonight, so I will be leaving halfway through the session. So apologies for that, because we're still on the COVID roster at Middlemore Hospital. So so Emma, over to you.
Lovely. Kia ora, everybody from New Zealand, and absolutely delighted to be talking to you this evening. I wish I was somewhere in the Pacific because it's pouring with rain here. Not very nice. And I was just reflecting today on my iPhone. Up came some memories of photos, and there in the memories was 2019 when I was in Apia for a week teaching there. So I know some of you might be watching. So hi, and apologies if you've seen some of this talk before. So Kara gave me a fairly broad brush and ultrasound, obstetrics and gynecology. So I've got a lot of slides and I'll probably go quite quickly. I can see the chat here to my left, and I know that Kara and Dr. Tapa will be keeping an eye on it. So I'll try and answer questions as I go, but if I can't, we'll come back to them at the end. So here we go. I just have to remember. I've also had my fiance helping me organize and make sure I'm doing this correctly. Okay, right. I'm just going to Make that full screen again. Okay, so obstetrics, I thought I would go through briefly the dating scan. The nuchal translucency, very briefly, I know it's probably not something you do regularly in the Pacific. What the elements of the anatomy scan might mean, I realise I'm not speaking to sonographers or radiologists particularly, so I'll just talk a little bit about what might be important for you if you're on the delivery unit, just doing that first scan, and the growth scan. So why do we want a dating scan? Oftentimes we find it minimal, and I just talked to a midwife today looking after a woman who just turned up and delivered. So we had no scans, we had no dating other than her date. So why is it important? Well, we know that what it does is it helps us to detect fetal abnormalities. It also increases termination of pregnancy, but actually in terms of some fetal abnormalities might be important for those women to be delivering somewhere else. So I know when I worked at Auckland Hospital, we had a lot of women come from the Pacific where they had detected babies had cardiac abnormalities. And those babies actually, by coming and being detected antenatally, actually had really good chances of survival and opportunities, whereas being born in the wrong place, even within New Zealand, meant that their outcomes weren't so good. It also allows us to detect multiple pregnancy and determine what kind of multiple pregnancy is. And that means that then the care through the antenatal period can be appropriately directed for that woman. It also reduces induction of labours for post-dates, although remember that's in maybe a different setting to the Pacific, but certainly here in New Zealand, we do a lot of inductions for women who are 42 weeks and more, and by having good dating, you reduce that. It's also reassurance for the woman, particularly a woman who's maybe had a few miscarriages or has had a stillbirth or lost a baby. And it allows for timing of screening procedures, which you may or may not be doing in your setting, but for here in New Zealand are important. For the women who present early in pregnancy with pain or bleeding, then a dating scan can be very important, but also the dating scan will sometimes show that there's actually a problem with the pregnancy. And it could be important, like an ectopic pregnancy. So how are we going to date a pregnancy? Well, we can do it with the last menstrual period and calculate it using an obstetric calculator. And these days there's heaps of them. We've all got our phones and we can just go and use one. Or use ultrasound, and that's the bit I'm going to talk to you about. So this is a nice scan. It's a transabdominal scan. So what we can tell is it's transabdominal because of the shape of the probe. So if you have a scanner in your department, almost certainly this is the sort of scan probe you have, and pretty much what you're seeing there that I'm pointing at with the arrow is the same shape as the probe that you will have, and it's kind of about the width of your hand. And here we can see this is a sagittal midline probe position, so just holding it low over the just above the symphysis pubis, and the bladder here is seen in black, and that's fluid in the bladder, urine obviously. Here is bowel, and you can see bowel kind of makes it really hard to see what's behind. And here we can see the pregnancy. So this is the uterus here. The white, bright, the echogenic layer is the endometrium, the lining of the womb. And here we see a little white circle, and there's a clue here, YS, it's a yolk sac. And so this is a pregnancy which is inside the uterus, and it's nicely at the top of the uterus. Down here, we're seeing diving away the bottom of the uterus and the cervix. And so this tells me straight away with one picture, here's a pregnancy in the uterus. I can see a yolk sac, maybe a hint of an embryo there, and that it's all sitting in the right spot. Now, if you've got somebody who's got pain or bleeding, this might actually not be the picture that you see. So that's a very useful tool to just be able to fill the woman's bladder, do that picture, and see straight away that things look okay. So if we're actually trying to date the pregnancy, here we can see that we can do a transabdominal scan and we can measure the first thing that we see, which is the sac. So the gestational sac appears first. We can measure it in 2 dimensions, and we can say, okay, is that a good size sac? And here, if you use an ultrasound machine, they often have settings that you can use, and they can tell you how many weeks the pregnancy is. Here, we've got a transvaginal scan. So we can tell because of the shape of the probe up here, it's much more curvy. And here, a transvaginal scan can be very useful to see the very early pregnancy. So here we can see that yolk sac again, and here we can see an embryo. Now, you can't actually see very much detail, but you can rotate until you see it as long as possible, measure from one end to the other. Here we can see it's 4 millimeters, it's about 6 weeks. And you might even be able to see the fetal heart as well. Now, I think you can probably all see that we're a little bit further along here. Again, this is a transabdominal scan. And this is a really lovely picture for a mum maybe who's lost a few babies, because what we can see here is this pregnancy is 9 weeks and 1 day. And we measure from the crown, top of the head, to the rump. I'm not going to jump up and show you the rump on my screen, but anyway, it's baby's bottom here. So it's the longest part. And this is a very accurate way of dating the pregnancy. Here, we can see a lot more detail. We can see the heart, we can see the abdomen, even a hand here, a lot more of the face and the head. And this here is the nuchal translucency, the bit of fluid behind the neck. And this measurement, again, goes from the crown to the rump, and we're now 13 weeks gestation. This is just to highlight to you that sometimes you might look and everything looks good. You can reassure the mum, she's presented with some bleeding, you've got a machine on your unit, you can show her this picture. She's really happy, she can see the heart. But you might put on the probe here and see something like this and you think, I don't know, that doesn't look quite like I would expect. Looks a bit unusual. And you need to think twice, because if you see something like this, it may well be that you're looking at an abnormality. And that'll be well worth organising a scan in your department, or maybe even shifting the woman to another town, even across a water to another city or another island, to actually have a good look at this. Because this is almost certainly an abnormality which is not survivable. It's going to be something like anencephaly or cephalocele. And so actually that's a condition where the pregnancy may continue, but actually this is not a survivable condition. And it's well worth seeking some help for that woman. So dating scan, we've seen all those different scans that we can do in the first trimester. The earlier the scan, the more accurate, except that I would say if you can only see a sac and you can't see a little embryo or a fetal pole, then that is not so accurate. You need to wait a week or two and get to the point where you can see a fetal pole with a little flickering heart rate. So from 6 weeks to 12 weeks, that crown rump length is going to be the most accurate way of dating that pregnancy. And it's going to be between plus or minus 3 days to 5 days. So if you think about when you're thinking about 40 weeks, it's a very narrow window. It might be 39 plus 4 or 40 plus 2. So it's a narrow window you've got there. If you see a fetal heart, then it will usually be from about 5 or 6 weeks. Crown rump lengths at those stages are going to be about 2 millimeters, maybe 3 to 4 millimeters. If you hit that window of 12 to 15 weeks, it may be that you're better to actually just wait and then wait till around 15 weeks. And then you start using some different measurements in order to determine the gestational age. And if you've got an ultrasound machine that's got an obstetric dating package, it will do this all automatically. I'm going to talk about all these measurements when I get to growth scans and anatomies, but these are ones which you're probably familiar with: the biparietal diameter, the head circumference, the abdominal circumference, and the femur length. But by now, because the babies will be different sizes to do with different conditions, such as a bigger mum, such as a third or fourth baby, where mums had bigger and bigger babies, you're actually going to get more variation. And so the variation around that date that you give is going to be more like a week at this stage. So here we have a scan showing the BPD at 13 weeks. And you can see this measurement is from side to side, and you can see here the thalami and the whole of the skull. So dates or scan, because this woman may have dates that she's absolutely convinced on, less than 20 weeks. If the dates and scan agree, then that's fine. It's easy. There's no question. But if you do a scan and the dates are more than 7 days different, then probably you're best to go with the scan. If it's less than 7 days, then go with the dates. Once you get over 20 weeks, nothing is going to be very accurate in terms of scanning. You might be plus or minus 14 days. And if the woman has a really good history of regular periods, no bleeding, not any contraception, then you're probably better to go with her dates. I just mentioned transcerebellar diameter. This is a measurement here. This is the baby's head. We've already seen that we need to see these two structures called the thalami if we're doing the biparietal diameter. But this is right at the back of the brain. This is the cerebellum here. And if we measure from side to side, we can see it's 20 plus 0.5 and she's 20 weeks. in general, roughly about the number of weeks, and probably the most accurate measurement for dating. Okay, I've got 3 slides on nuchal translucency. The nuchal translucency is that bit of skin that's lifted by fluid at the back of the neck, and it's a very difficult scan to perform. It requires a lot of skills and training. It's effectively been developed. It was developed by Kypros Nikolaidis at King's College London, and it was developed to be used between 11 and 14 weeks to detect babies with Down syndrome. And so it's become part of a routine measurement that many women have around the world. And in New Zealand, we use this plus some analytes from the maternal blood to actually determine what the risk is for Down syndrome. The detection is very good, but it's really important this is done really well. So this is not something I would recommend that you pick up and do on an ultrasound yourself, but it is there and it is part of the screening that we do. This is why it might be useful for you to know the 3 slides that I'm showing you, is because if that nuchal measurement's very thick, then there may be some concerns for that baby. Yes, it might have something like Down syndrome, but it may also have structural conditions, like we know it predicts for structural heart conditions. And I already talked about the fact that those are good to detect because they may mean the baby needs to be born somewhere else. It may be part of a complex syndrome, or it might be that there's a problem with the way the placenta is developing. Now I'm talking very quickly, but that's because I've got a lot to get through. So I'll just keep going. I'm looking, no questions. Okay, we're all good. Anatomy scan. Now, doing an anatomy scan, it takes a long time of training and education to do that. It's not something you should just pick up the probe and do. However, it's designed to pick up abnormalities and identify small babies, and it's sometimes used for dating. But I think the part of it that I think is most useful for general obstetricians, midwives, maybe nurses who are looking after women who pitch up, maybe at 25 weeks with bleeding, never had a scan. Yes, you might identify if there's a major problem, but I think placental localization is probably one of the most useful things that you can understand if you're doing an anatomy scan type of timing. So again, it's the same picture, and this is a lot easier if I'm standing with you and up here to explain and show you, but basically it's a midline sagittal, so coming this way, just above the symphysis. And here's your probe. It's that curvilinear probe again, the one you put on the woman's abdomen about the width of your hand. And what you can see here, this is the skin here, coming down through the layers. We can see the fat, we can see the muscle. Here, this is the rectus abdominis, and here is the uterine wall. That any brightness is a strong interface. Here it's the baby's skull, here it's the wall of the uterus and the serosa. Beneath it, this is the uterine myometrium. Anything black is fluid. There's a little bit of urine in the bladder, but not a great deal. Here is the light core around the baby's head. And here's somebody who's measured the cervix. Now the cervix might go this way or this way or this way. Here it's pointing upwards. And so what you're looking for is, well, what is coming first? This woman's coming bleeding, maybe contracting. Let's look what's coming first. And what we can see here is baby's head, nothing in the way. Maybe that's placenta there, maybe it's there. If we went higher, we might be able to see the placenta well. And so we're not too worried that that bleeding might be something serious. Compare with this picture. Again, 20 weeks, little bit of bladder in the urine in the bladder. Here's the fat, the muscle there. Here is the wall of the uterus. Now, what is this? This is placenta. Cervix is way down here. So if you put the probe on and you saw this and the baby's up here somewhere, then you're crikey. This is a complete placenta previa. This woman is bleeding. I know she's only 20 weeks, but this is important. Actually, this woman might start bleeding very heavily. And so this is really useful stuff you can do in the delivery room, you can do in your assessment unit. And you know that if you don't have the capacity to manage heavy bleeding, you need to think about how and where this woman should be managed. That's all I'm going to say about anatomy scans. I have lots more I could say, but I don't think it's necessarily relevant for this audience. I've just got a couple of scans on cervical length assessment. Now, in the Pacific, on the different Pacific islands, different nations, there will be different abilities to care for preterm babies. And there may be opportunities to transfer out preterm mums who are at risk of preterm birth. Now, the cervical length is about that assessment for women who may present with some pain, very preterm, or maybe have lost babies preterm in the past. And so really that gives us a bit of a clue as to whether this woman is likely to have another preterm birth. And it might be she's got the opportunity in her next pregnancy to relocate to New Zealand or somewhere else where she could potentially have treatments for preterm birth or potentially have a preterm baby. So when we're assessing the cervix to tell us about what is that risk, we can do a transabdominal, a translabial or transvaginal scan. And generally transvaginal is considered the gold standard for assessing the cervix. When would we look at the cervix? Well, as I say, someone who's had previous cervical surgery, someone who's lost babies, where you think it might be cervical incompetence, women who've maybe had very early preterm rupture membranes or previous preterm birth. When might you look at the cervix? Between maybe 14 and 18 weeks. But equally, the slides I'm going to show you could be for that woman who maybe at 28 weeks or 24 weeks presents with pain and you're thinking, is this preterm labor? So this is a slide here that just shows you the transvaginal scan. So we've got that real curvy approach, and that's the transvaginal scan. And basically it's a long probe, which is about the width of my thumb, goes in the vagina. And here we can see, so it's a different view. You're coming from the inside. What about incompatible cervix? Okay, I'm not sure what you mean. Maybe if someone can have a think about how to rephrase that, I will answer the question. So here we go. Incompetent cervix, maybe. So here is the bit of the bladder, and here is the rectum. Here is the cervix, all of this. And we're measuring from the inside of the internal os to the outside. And here's his baby here. I think that's spine and fluid. And so this measurement is also being done with fundal pressure. And this is about 30 millimeters, and that's okay. So it should be somewhere between 25 and 50. It should be closed throughout its length. And you can use this fundal pressure to double check. Yes, sorry, typing error. Yeah, so the incompetent cervix, what about it? Well, I'll come on to that in a minute. I'll finish these pictures first. So this is roughly what a normal cervix should be in pregnancy. Now, the interesting thing is that I'm faced quite often here in New Zealand with people saying, whatever the gestation, 25 millimeters and above is normal. But what you'll see here that's really interesting, this is a very old study, you can see from the picture, but not a lot of studies have been done like this, but this has followed all these women, whole bunch of women through their pregnancy, measuring their cervix every couple of weeks. So most women don't want their cervix measured every couple of weeks, but what you can see is that at 10 to 13 weeks, a normal cervix is actually 5 centimeters or 50 millimeters. Whereas at 37 weeks, it's more like 35 millimeters. So if you have a woman who you're scanning at 14 weeks and her cervix is 30 millimeters, that's actually pretty short already. So what happens to the cervix when it opens up? And this is a little bit leading into that incompetent cervix. So I think sometimes we think saying the word incompetent can sometimes be quite hard on women because they feel like, crikey, I'm incompetent, I can't keep a baby in. But I think what we talk about is the cervix that basically opens up, and it opens up generally in a certain way. When we think about these letters of the alphabet. So to start with, the cervix is holding the external os, the internal os, and you've got this kind of T shape, but it gets a bit shorter. The next thing that happens is that the internal os starts to open, whereas there's a nice closed length out to the external os, and you get this Y shape. The next thing is that it opens all the way out to the external os, and then you get a V, and then you start to get that U shape, which is, if you think about it at a full term labor, is that effacement starting and the lower segment being pulled up and effaced. So when you have an incompetent cervix, what we're talking about is this process is normal at full term. It's a very normal process. But when we talk about an incompetent cervix, we're talking about this process happening at a time when it shouldn't happen. And how do you manage it? Well, that's a whole extra lecture I haven't gone into. But here in New Zealand, we have access to progesterone. I'm not sure if you do in the Pacific, but that's a very easy, non-interventional way to manage a pregnancy where someone's previously lost a pregnancy because the cervix has shortened. However, if you know that you're scanning a woman and you're seeing a short cervix at 14 weeks, probably the best thing to do with a history that's really clear-cut of a loss of a pregnancy of 14 to 18 weeks is actually to proceed to putting in a cervical suture. Now, I'm not going to stop and explain how to do that, but many of you will be familiar with doing that, particularly with maybe if you've done attachments overseas, you'll have had the opportunity to do it. You may well be doing it in your centre. So with a good history of an incompetent cervix, and if you are pretty sure that's what's going on, then putting a cervical suture may be the best option. I've got some ultrasound pictures to show you. So if you have got access to a transvaginal scan, I've already showed you a short cervix, but here we can see that V developing. So here we've got the V with a short length of closed cervix, just 11 millimeters. Here we've got the V, which is open cervix here, but actually look, you can see fluid all the way down here, almost the external os. So this situation is one where maybe you might put in an emergency cerclage. You might try and put a suture in at that point in time. In this situation, probably you've missed the boat. This is a transabdominal scan. So if you've got a woman in your unit who comes in and she's 24 weeks and she's got pains, here's the bladder. You put this on and you see this picture. And this here, if you go and do a speculum examination, you want to be very gentle because you're probably going to see membranes bulging in the vagina. And it's going to be really tricky to decide what you do. And it depends a lot on what your experience is and what you've got in your unit to support you. This is even worse because here is actually the internal os now and the baby is already through. And at this stage, there's pretty much nothing you can do. You've really just got to support that woman because actually you've probably lost your chance to do anything. Somebody's had a look to see if there's any cord presenting, so that if, for example, this was a pregnancy where you could actually go for the baby had a chance of survival, then you know that, okay, there's no cord here, then probably I'm just going to let that baby deliver on call in a breech position. So that's the end of those slides. I'm now going to move on to the growth scan, which I think is probably the sort of scan that you will hopefully be having the opportunity to do. Please keep firing your questions. Okay, Ropely, thank you. I'm keeping an eye on the questions. Okay, so I think it's always good to have a routine. And I think if you don't have a routine, it's easy to miss things. So what I'm always saying to my trainees is have a deep field of view. And by that, I mean is you don't just want that top bit. Yes, I can see the baby, I'm done. You want to see right to the back of the uterus and even beyond. And that way you're not going to miss things like a second pregnancy, like, it's twins and actually there's one hidden at the back, or you've got a big ovarian cyst right at the back of the uterus and the pain is due to that twisting around that she might be presenting with in her pregnancy. You want to think about the presentation, what's coming first. You want to look at the cervix in that, we've already seen plenty of examples of that transabdominal sagittal view through the lower part of the uterus just above the bladder, so that you can ensure that you know what's presenting. There's no cord presenting. We've got maybe a head, hopefully a head, no cord, no feet, no arms, and also that there's no placenta. So that's really going to give you that safety factor straight away when you do your first picture. Then you're going to look through the uterus. You're going to look for the placenta, the fluid, check the baby's heart. Most women, I've drummed this into my trainees. It's funny, we think that women are just all casual and relaxed, but actually they're often lying there, particularly when they've come in with either bleeding or pain. A lot of them think there's something really serious and maybe their baby's died. So the first thing I do is go straight to the heart and say, hey, look, there's your baby's heart, just to reassure them straight away. And if you're confident, you might be looking for anomalies, or there may be something really obvious is wrong, in which case you need to get some help with that scanning if you can. Okay, so then once you've done your nice big view, really deep field of view, you can see right to the back of the uterus, you've looked through everything, then you can start focusing on some of your measurements that you want to do. So measurement of the biparietal diameter requires you to have a nice oval shape, the thalami, no cerebellum. So I showed you that cerebellum earlier. You don't want that when you're doing your biparietal diameter. Cavum, septum, pellucidum, and I'll show you in a minute. And you're going to measure from the outer bone to the inner bone. Head circumference, luckily for us, is at exactly the same level, except you're measuring around the baby's skull. So here's a picture. So these two dark black areas are the thalami. This white line in the center is the falx. So this is the midline of the brain. These two white lines here, which are parallel either side of the midline with a black box in the center, that's the cavum, septum, pellucidum. Here, we can't see any of the cerebellum that we saw earlier, so that's all normal. So this is a perfect picture to do your biparietal diameter and your head circumference. So the biparietal diameter is from the outer edge of the bone to the inner edge of the bone, and it's at the widest point of the head. The head circumference is all the way around the outside of the bone, around the baby's head. Just going to be moving on to our next slide, potentially, if my, yeah, there we go. Measurement of the abdominal circumference. This is harder to get correctly measured, and so there's more variation. And so for the abdominal circumference, I normally recommend doing 3 measurements and taking the average or picking one that seems like the really good one. So it's a transverse section through the abdomen, as round as possible. And you might need to roll the lady. So she might be lying on her back or on her side, and you think it's not that round. If you roll her the other direction, suddenly you've got a beautiful round abdominal circumference. You want a transverse spine and a short length of one of the ribs. You need to see the stomach and a little bit of the umbilical vein and right portal vein. You don't want kidney, bladder, heart, because that means you're actually in the wrong angle. Okay, so here we can see, here's the spine here. Here's the umbilical vein here coming through, nice little curl. So it's not right out to the skin, it's starting 1/3 of the way in. And here's the stomach. And we're measuring outside. And this is definitely something that is not necessarily easy to do. It requires a bit of practice. But you can certainly get a ballpark. Last one is the femur length. And so what we want for the femur length is we want the full length of the femur. Ideally, you want it 90 degrees to the beam. Remember I said that the whiteness, the echogenicity is to do with the interface, and it's where the sound beam is best reflected back. You want to see both ends clearly, and you want to be the skin at the end. You measure from the bottom of the U either end. So here we can see we've got 90 degrees to this bone, so it's going to be very bright. We've got the calipers coming in at the end. Okay, now I have whizzed through obstetrics very quickly. I've given you a cook's tour, as they say, and I've now got lots of gynecology pictures. And I just want to take a second. Any questions that anybody wants to ask? I've got lots of other images I can show of obstetrics, but I think I might move on to gynecology. No, I'm not seeing anything coming through. Wonderful. Okay. And welcome to Dr. Tapa, who has joined us, who I'm pretty sure we met before. Okay, right, moving on to gynecology. Wow, there's a lot of reasons why you might want to do a scan for someone who presents to your gynecology room. Pelvic pain, possible cyst, heavy periods. You might just have examined her, felt a big mass and think, crikey, is that something, or is it just a lot of constipation? Fibroids, bleeding after the menopause. So there's an awful lot of things here. So I tried really hard to think, well, what would be the most useful things for the gynecologist, the nurse working on a gynae ward that they could use. So I've tried to sort of narrow it down a little bit. I'm not sure how well I've done. So apologies if I've got too much stuff in here. So again, if you've got a transabdominal and transvaginal probe, that's excellent. I know when I was in RPA, there was a bit of a range. It was mainly just transabdominal probes, but we'll talk through what we can see. The transvaginal is not generally performed in women who are not sexually active, but you can do a translabial. And the way that you do that, you ask the woman to, you basically take your transabdominal probe, your curvilinear, you can put a glove on it or something plastic that will go over the top, and then you just hold it at the vulva, and you can use it that way, and you can actually get some really good pictures sometimes. For twin pregnancy, question just come through, should we measure the length of the cervix frequently? Sadly, no. Twins, we really struggle to find a good way of assessing their risk of preterm birth. I think if they have any other history or they present with pain, then yes, but it's not something to do routinely. So, male sonographers generally should have a chaperone, and this talk I wrote originally was for sonographers, but I think that's true. And actually, in New Zealand, we're now recommending that I always offer a chaperone anyway for anybody. Not just, even though I'm a female doctor, I still offer a chaperone. For a transabdominal scan, you definitely want a full bladder, and then you want an empty bladder for the transvaginal. So they're useful and complementary. I'm going to show you some images that show where it's actually useful to do both. So you don't normally do a transvaginal scan in isolation. And if you're doing a full gynecological examination, a pelvic scan, then you would do kidneys and bladder, and I'll show you a couple of those pictures. So for a transabdominal, you know this, the woman lies on the bed, you image the bladder in a longitudinal and transverse section, you look for the ureters, you look at the uterus in a longitudinal and transverse section, you measure it, and you measure the endometrial thickness, identify and measure the ovaries, and ideally the kidneys too. For a transvaginal scan, you would get consent first, you'd ask the woman to empty her bladder, give her an opportunity to undress in private, and then cover her with a sheet. Now, the probe, if you're using the transvaginal probe, should have a probe cover with sterile gel and then be inserted. Now, what I often will do is actually ask the woman to insert the probe herself. And that gives that woman control and ensures it goes into the right spot. And so then once she's inserted it, you can take control. So this is a transabdominal scan. And the reason I'm showing you is because it's actually a really nice scan. So here we can see our curvilinear probe. Here we can see the bladder. This lady is desperate for a wee. She's got a very full bladder because she's got a wonderful, wonderful picture of her uterus here in longitudinal. So this would be just above the bladder in a sagittal section. Here we can just about make out the endometrium. Now I can see that Rupati's got his hand up. Rupati, do you want to cut in, and have you got something you want to ask? You're on mute.
No, I'm okay.
No, your hand's up though.
Oh, sorry.
Okay, right, hands down again. Cool. I've been doing a lot of Zooms recently, so I'm pretty savvy. I noticed the hands straight away. Okay, so no hands up, good. All right, we'll keep going. So this transabdominal scan, I wanted to show you what a great picture is. So this is your longitudinal uterus. Here's your endometrium here. Not the best picture, but you can see it, and this is the cervix here. Now, this lady then, this is exactly the same lady, went on and had a transvaginal scan, and they had thought, well, I'll assess the endometrium on the transvaginal scan. So remember, now she's emptied her bladder. This is a horrible picture because this uterus is what we call axial. So it's not really anteverted, it's not really retroverted, it's kind of axial. So trying to measure that endometrium is really difficult. So they are complementary, and it is worth actually taking the time to do a good transabdominal scan. This is a much nicer transvaginal scan because this is an anteverted uterus, and we can see it really clearly. And so here's the endometrium, we're going to be able to measure it very well. So what does the endometrium look like? How do we assess it? It's got two layers. It's got the functional layer, the zona functionalis, a superficial layer, and the deep basal layer. Don't worry about the names, you don't need to know it. But it means that these two layers do change through the menstrual cycle. So early in the cycle, if you think about it, the woman has just shed the endometrial lining, you're going to have a thin endometrium, and it appears as a hyperechoic line. So a bright hyperechoic, bright echo line representing blood and tissue. As the cycle progresses into proliferative, you're starting to see some building up. So you see a thin stripe now with a hypoechoic. So that's a darker halo creating this 3-line sign. As we get into the secretory phase, it increases in thickness and more echogenicity again. And once we're close to menses, you've got a very thick and echogenic again endometrium. Postmenopausally, the endometrium should be thin. And if it's not, then you need to be concerned, particularly if there's bleeding. So here we've got a nice picture of the uterus. It's anteverted, it's a transvaginal scan. And here we can see our 3 lines. That's the thin echogenic center line and the hypoechoic lines either side. And the measurement will go from here to here, and that would be our endometrial thickness. And this is a diagram which basically takes you through all those different stages sonographically of how the endometrium changes through the menstrual cycle. And here's a measurement, 1.1 millimeters. It's very early in the cycle. She's got a very thin endometrium. She's just had her menses. Here we are a little bit later, so we can see that thin white line, but we can see that halo of darker echolucent around it. And here we are in the secretory, and you can see now actually it's very echogenic, it's a lot thicker, we've thickened up and almost ready for the menses to occur. Now you might be wondering, here we have the uterus, we've got these black holes here down in the cervix. Well, those of you that are on the ball will be thinking, black cystic spaces, fluid filled in the cervix, they're actually Nabothian follicles. So they're very normal. So we measure it perpendicular to the long axis of the uterus. The halo is not included as it represents the inner compact layer of the myometrium. And if there's fluid in the uterus, we don't include it. We measure either side. The normal measurement will depend on the hormonal status, pre or postmenopausal, and also on the stage of the cycle. So in postmenopausal women, it should be less than 5 millimeters. If they're on HRT, it's allowed to be a little bit thicker. But you need to have a little look for cystic changes. So this is a very thick endometrium all the way across here. And someone's put some color on, and what they can see is here is the endometrium here, and there's a lot of color in there. So that would be a bit suspicious. Now, if this was a postmenopausal woman, you'd be quite concerned and you'd want to go and sample inside and check that that's not an endometrial cancer. And as we know, endometrial cancer more common in women with obesity, so really important. What about polyps? Now, they're a lot more common. They can be asymptomatic, they can cause irregular bleeding, they can even cause postcoital bleeding. They often have a vessel, and that's often on ultrasound how we figure out what they are. They may well have some fluid in them. I'm going to show you a really obvious one. Now, that is a barn door one, okay? I've got one which is way more subtle, but here we have a TV scan. We can see this is the endometrium coming around here. We can see there's a bit of fluid. That's very lucky for us. And here's something inside the endometrial cavity. Makes it very easy to see with blood flow. And here we can even follow that vessel that's coming from the myometrium into this polyp. I have to say, this is not normally this easy. There it is. Retained products of conception. So this is something that, you know, we all see quite commonly, sadly. And we know that we've got a positive pregnancy test, a positive beta-HCG. So we're trying to figure out, this woman presents, she may have had some bleeding early in pregnancy. She still feels pregnant, but she's not sure. And now she's presented, and you maybe 3 o'clock in the morning, you've got an ultrasound machine, like, okay, I'm going to have a look, see if I can figure out what's going on. Well, you already saw the scans I showed you what an empty uterus looks like. So we saw that thin endometrium, nothing inside. So I'm now just going to show you one picture, which is really quite obvious. If I can get it to move forward, here we go. So this is a transvaginal scan, but often you can do this transabdominal. You can get the woman to fill her bladder and you can have a look. But here This is the myometrium, but here we can see all of this mixed echogenicity. It's heterogeneous. It's bright, it's dark, it's bright, it's dark, and it's carrying all the way down. And here we can see the lining of the cavity, but we can see all of this stuff here, and it's even sitting in the cervix. And so this is all looking like blood clot retained products. But to be retained products, what we want to see is a bit like the polyp before, is a vessel which is coming into this tissue. Otherwise, it might just be a miscarriage that's still in process. Okay, we're on to fibroids. So these are common, and this is one of the times when it's really important to make sure you do a transabdominal as well as a transvaginal. They're very common. It might be that you see a woman, she's maybe in her 60s or 50s, and she's got some pain and swelling and bloating, and you put your hand on her tummy and you feel, crikey, what can I feel? It's very nice to be able to do a scan and say, actually, I think that's just a fibroid, because actually the alternative is probably something more serious. In pregnancy, they can increase in size, but they don't generally cause any problems. Generally, after the menopause, they tend to regress. So if it's a new thing that is found after the menopause, then it may well be something serious. So they can be in different areas. They can be submucosal, which means they're inside the uterine cavity, and they can cause really serious heavy bleeding, menorrhagia. But the majority of them are intramural. So they're usually within the myometrium. They can also cause menorrhagia as well. And then a small number of them are subserosal, which means they're coming off the surface of the uterus. They can even be on a long pedicle and end up kind of anywhere within the abdominal cavity. So that's a pedunculated fibroid. A transvaginal scan can be useful for assessing the origin of a mass. Small ones tend to be hypoechoic. Now, what we mean by hypo is less echogenic, so less bright, less of a response, less of a bounce back from the sound, so they're dark, but they can be echogenic if they've got dense fibrous tissue. They may get calcification, and that can cause shadowing behind, and you might even get like a white rim around them if they're calcified, which shows them really obviously. They can also get cystic degeneration, and we see that in pregnancy. So here's a transabdominal scan, and you'll say, okay, I can see a uterus there that's measured up very nicely. But the thing that's interesting is here's the bladder, and you might see, hang on, here's the uterus. Here's where that bright echo finishes, but now I'm sort of seeing something up the top here. And this is why transabdominal scan can be really important, because here we are off slightly to the left on that exact same uterus. And what we're seeing is actually, look at this, something that's coming right off the top of the uterus. So when you're doing your scan, you're putting the scan probe, you're seeing the uterus. Remember to go up. So remember to go to the side. Remember to have a good look around and make sure that you don't miss a big fibroid sitting off the top of the uterus. Look at this, 5.4 by 6.1 centimeters sitting off the top of the uterus, and 5.8. So this is a fibroid. In the same scan, we're having a look at the bladder, and here is a flash of color. Now, you may or may not have access to Doppler. All Doppler does is tell you when there's fluid moving. We think of it as being something to assess blood flow in the fetus or in vessels, but actually it's just fluid moving. And here what we've got is we've got a ureteric jet. So this is urine coming. So if you've done a cesarean section on somebody and the urine is a bit pink and you're a bit worried that maybe you've nobbled a ureter, get her to clamp the catheter, fill up the bladder, do a scan, and have a look to see if those ureteric jets are firing. You might have to sit there for a few minutes. They don't fire all the time, but you see this and one from the other side, you're going to go, I think we're okay. Good trick. So this is the same uterus, and this is now a transvaginal scan. Now this is a Marina IUCD, which is that funny look in there inside the uterus. But what we can see is that actually it's got a normal shape, top of the uterus, normal size. But actually, if you go off to the side, here's the fibroid. But here's the thing. We can't see the top of this fibroid because with a transvaginal probe, it's very high frequency, means it's very good at seeing near objects in very high detail, much better detail than the transabdominal, but it doesn't penetrate very deep, so you can't see very far. So that's why you need your transabdominal scan to see this fibroid. So that's fibroids. Adenomyosis. This is a type of endometrial tissue, which instead of sitting in the uterine cavity is in the wall of the uterus, and it can cause menorrhagia and pain and also infertility. And when we look on scan, we see this sort of like white lines coming down, and that's our adenomyosis. Ovaries. So this is the other thing that I think is well worth knowing about in order to be able to do a scan to assess women coming in. So you might find that someone's got a malignant mass, or they might have a benign mass. But it is important to have a look when someone presents with abdominal pain and you do a speculum and a bi-manual examination, and you're not sure if the ovaries are enlarged or not. So here we have a transvaginal scan showing a normal right ovary. So here's the ovary here. And you might say to me, hang on, what's that in the center? Well, that's actually, if you think about your anatomy books and a corpus luteum, that's actually collapsed corpus luteum. And it looks just like it. It's a good example. And here we can see when we put the color on, there's blood going all the way around, and that tells us that that's what it is. Here's another picture of it. You can see a bit more of the ovary there. And this is one where someone has said the right ovary moves freely. So when you're doing these scans, really important to just get a feel for whether these structures are moving around nicely. So if you find a mass, you need to think about the symptoms. You need to think about, is this woman pre or postmenopausal? Could be just a simple physiological cyst. Now, if it's a simple physiological cyst, it will be clear. It won't have any strands. It won't have any echogenic white bits. It will just be a black cyst within the ovary. However, endometriomas are quite common. So we're talking about endometriosis now, which is within the ovary creating an endometriotic cyst. It's well defined, they have thick walls. They have what we call low-level internal echoes. So here we go. Here is a big cyst on the ovary, and you can see all these little white spots. That's our low-level internal echoes. Sometimes it's called a ground glass appearance. I guess it kind of looks like ground glass. Here's another example. We've got 3 endometriomas here, all bunched up together. What about dermoid cysts? These are really common. They're common in young women. We see them in pregnant women and non-pregnant women. 1/5 of them are bilateral. As I say, 80% current childbearing age, and they're generally benign. However, they can twist and cause torsion. They usually have a fat fluid level, and they're often mistaken for bowel. So this is one here. I must say it's a bit tricky. It looks a little bit like our endometrioma we already saw. Here's another one though. Look, see this white? This is what we would consider looking like fat. We've got a follicle here, a bit of ovary, and then this and this. It's all a bit of a mess, but this is what gives it away, the white echogenic area. Here, we've got actually, if you think about it, a woman lying down, and we're doing the scan. So we've actually got a fat fluid level here. So we've got a echogenic area and a more echolucent area, all in the one spot. So this again will be a dermoid. This is actually a dermoid, but you've got a little white area of fat, so you've got a complex. And the thing that really can make it difficult, because you're thinking to yourself, well, maybe this is a neoplasm, is actually to think about the age of the woman and to actually put on the color to check whether there's any vascularity. So in a dermoid, there won't necessarily be any vascularity. It's a younger woman, and it's often bilateral. The neoplasm is going to be your older postmenopausal woman. Again, another example, a little bit of fat in that ovary. So what about ovarian torsion? This generally will present with a lot of pain, and we've used transvaginal scan to try and figure this out. Well, the ovary actually has a dual blood supply, so you know it doesn't necessarily mean it's all lost. But if you think you've got a torsion, then you're going to want to get to theatre quickly to try and save that ovary. Usually occurs in younger women. And as I said, it generally is an association with an adnexal mass. It's big enough to twist the ovary. What it gives you is an enlarged edematous ovary. So it loses a lot of its architecture. So normally you can see the follicles. I showed you that corpus luteum, but it just loses architecture. There may be a bit of free fluid, and there might be some vascularity or not much at all. So here we've got a normal ovary. This is in the pouch of Douglas, a bit of free fluid. Here is the other ovary, which is torted. So you can see it's bigger, and you can see it's kind of lost its edematous, and it's lost a lot of its normal architecture of the normal ovary next to it. So then we put the color on. Well, we can see some nice normal color flow here, but not very much here. So this is a torted ovary. So in this situation, you want to get off to theatre and untort that ovary and save it if you can. Ectopic pregnancy. Now, this is definitely something that you want to know about if you're, sitting on your gynae ward or your A&E and you're asked to come and see a woman who's got a positive pregnancy test. She might be 8 weeks pregnant. She's not sure, no idea. No one can feel the uterus. They can't hear a fetal heart. How are you going to assess her on your scan? Well, the first thing is she's going to have an empty uterus. So you're going to do a transvaginal scan. Hopefully you'll have a probe. There's nothing in the uterus. You may see a mass in the adnexa with vascularity, with blood flowing to it. You might see a gestational sac in the wrong place. The other thing to be aware of is probe tenderness. As you're gently using your transvaginal probe, you're saying, is that sore? And if she jumps when you go near to something that looks suspicious, then that is much more likely that's an ectopic. You might also have free fluid, which might be echogenic, suggesting blood. So here's a picture. We're kind of familiar with this picture now. It's a uterus. It's got an endometrial measurement here, but there is nothing in there. We don't see that nice sac that we saw when we were looking at the dating scans. Nothing. So we're going to come up now to the right adnexa. So we can see something here. And we think, okay, what is that? That's 15 millimeters. Maybe that's the ovary. Maybe that's the ovary. What's going on? Still measuring it, not sure what this is. So we're going to put a bit of color on it, and then we're going to come up close. And what we're actually seeing is that this is actually a gestational sac. And what we were looking at separately is a separate ovary, and then we can measure it and see it's about 6 weeks size. And so if we look at the pouch of Douglas, we might see a lot of fluid here. So fluid is generally black, but it's got some dots in. Or we might see this is actually fluid, which was turned out to be blood in a different woman, but you can see it's very echogenic, very different. So if you've got a suspicion of an ectopic and you feel confident to do a transvaginal scan, if she's got a positive pregnancy test and there's an empty uterus and you can see something at the side and then you can see a fetal heart, then you can feel fairly confident. Now, if we have a bunch of cystic masses, what do we think of? Well, assuming we've done a negative pregnancy test, we're going to be thinking of a simple cyst, a paravarian cyst, a whole bunch of things: cystadenoma, cystic teratoma, endometrioma, and finally a tuber ovarian abscess. What do you need to consider? I realize I'm 3 minutes up to my end time, so I'm just going to whiz along. I think I'm nearly finished. You need to think, is it cystic or solid? If it's solid, it's suspicious. If it's cystic, is it simple or complex? If it's complex, which means it's got several compartments, then it's more suspicious than if it's simple, which means it's just one cyst. Size, where is it? Has it got vascularity? I'm just going to skip over this one just to show you some pictures. And so here we have a transvaginal scan. We've got several compartments of this ovarian mass. It's cystic, but look here, it's got this solid component here. And if this is a postmenopausal woman and she's got cystic and solid, then you're probably looking at an ovarian cancer. Here we have another picture, several cystic areas, no solid areas to talk of, but again, in a postmenopausal woman, you've got to be suspicious. And again, this one, a solid area. Okay, not sure what's going on. I finished with 1 minute to spare. Thank you very much. I have lots more pictures I can show you, but I'm going to stop there, and maybe I'll be asked back to do a different talk with more pictures on another day if you haven't had enough. Thank you.
Tapa, you're on.
Yes, hi. Sorry, Betsy. On now. Just wanted to apologize firstly for due to the daylight savings and time difference.
Can you put your video on, Tapa?
All right, yeah, just
Yep.
Here we go. Hello.
Hi, Talofa.
Hi, Talofa lava. Hi, Emma.
Hi, how are you? I wish I was in up here now.
We would love to have you back.
Yeah, I'd love to come back.
My sincere apologies to you and Betty and the team. Pacific greetings to everyone as well. We didn't realize that because Samoa has actually canceled its daylight savings, so we were still, yeah, we thought we were an hour ahead. But yes, about the presentation, just wanted to say huge whaftai lava. I see a couple of Samoans on the here, and I think Glenn, our boss, also has joined the online sessions. And I just wanted to ask Emma I remember you mentioned this before in regards to ectopic, because I think it's probably one of the killers in our Pacific women, considering some of the barriers to access in early interventions. We had some cases in the past where we initially thought that there was a gestational sac in utero, but it was actually a pseudo sac as opposed to a true gestational sac, and of course with the a possibility of a blighted ovum. So would you care to comment on that, please?
Yes, so I didn't go into detail on that. Obviously, I tried to cover a lot of stuff, but the pseudosac is basically where you see a little echolucent area within the uterine cavity. Because there is a pregnancy somewhere, you get the endometrium quite echogenic and bright, and what we call that endometrial reaction. So it's very confusing. And in that situation, we're in the same boat, that you've got the you've got this pseudo gestational sac that makes you think you've got an intrauterine pregnancy. But I think the question is that you need to follow it through, rather than say that's it, it's an intrauterine pregnancy, is follow it through. So if the woman's high risk for ectopic, she's had PID, she's had previous ectopics, she's had tubal ligation, then you need to kind of follow it through to the point of, yes, it's definitely an intrauterine pregnancy. Do you guys have access to the quantitative beta HCG or just the positive negative?
We do have beta HCG now, so
yeah. Okay, well that's really helpful, because what you can do, I mean, essentially for a transvaginal ultrasound, once the beta HCG reaches maybe 1500, 2000, Glenn might correct me on this, then usually you should be able to see a yolk sac and a fetal pole. So I would suggest that you need to combine it with your beta HCG. So if your HCG is say 500 and you've got what looks like a gestational sac, you can't assume it is until you've followed it through and watched that beta HCG increase. So what I would be recommending to our doctors here in that setting, if I was doing that scan, is do the beta HCG every sort of 2 to 3 days over the next sort of 6 days or so, and watch that it's doubling nicely. And if it's doubled nicely and you're kind of at that 1500, 2000 threshold, then do another scan, have another look, check that has progressed to become an intrauterine pregnancy. And if it hasn't, then you have to consider, okay, this may well be an ectopic now, we can call it.
Thank you. Yes. I'm sort of allowing our other members in the Pacific to ask questions before I ask my next one, but I'm just checking through the chats. And...
yeah, I'm just looking too. I'm just having a look to see.
The floor is all yours, Tapa, and you can also close it for us. You just keep asking your questions, and you can close it for us afterwards.
Before I just wanted to, because Samoa has a huge problem with late bookings, and sorry, we've got one here from one of the Samoan participants.
So why?
Tali Swangas, yes.
So
I'll hand it over to you, Emma. Yep.
Yes, I'm not sure I 100% understand the question, why you're thinking to reduce induction of labour in post-term. So I think I think that maybe relates back to my very early part of the talk on dating, which is that Cochrane review that says that dating is useful to reduce inductions of labour post-term. So if you haven't had a dating scan and you're going on the woman's dates herself, then quite a number of those women's dates will be incorrect. And so actually you may end up doing more post-dates inductions, because the dates you get from her LMP will actually be earlier than if you'd done a scan. So if you did a scan, we'd actually say, actually, 10 weeks, you're 8 weeks. And so you'd bring them back. So it happens more that way, that the dating scan brings it a bit earlier, then it makes it a bit later. So you save on inductions a bit. Does that answer your question?
All right, that's Tali.
Hopefully, yes.
Yes. I think you've, thank you very much, Emma. I think you've touched on basically what I was going to ask in regards to dating. We've got a huge problem in Samoa, as you may have already known from your previous visit here.
Yes. And I keep wondering, how did that cesarean go on that lovely girl who had the breech that we scanned in the clinic? So, I'm hoping all right.
She did really well. Baby came out okay.
Good. Yeah, and I hope once our borders open up, I'd love to come back to the Pacific and teach again, because of having lots of unsure dates. Yeah. Yes. So yeah, it's good. And as I said in the talk, is if you've if Glenn and the team are happy to use those nomograms for transcerebellar diameter, they can sometimes add a little bit more accuracy to the dating as well. Yeah.
Fantastic, thank you. Well, I think if there, not sure if there's any other questions. Yeah, I don't see any. And thank you very much, Emma, on behalf of the Samoan contingent, and also I'm pretty sure some of our Pacific colleagues, there's quite a few of them actually, have tuned in. So it's fantastic turnout. Thank you very much for the basically a refresher, and also because Tali is actually one of our new midwifery colleagues. There's 2 of them. Actually, I see 3 who were on, and I've also invited them to be on this webinar. So thank you very much. We're hoping to get you across for our basic and advanced training again in the near future.
That would be fabulous. Yeah. Okay. And yeah, I've really enjoyed having the opportunity to catch up with you guys again. And thank you for having me. So best of luck, everybody. Yeah. Take care.
Great. Thank you very much. Betty, do you wish to
No, you can close it with what you can close it with a word of prayer, and then that's it for us, Tapa. Thank you very much, Emma.
Sure.
You're welcome.
Okay. Thank you. Okay, let's pray. Thank you, dear Heavenly Father, for your guidance tonight, and thank you for Emma for sharing her knowledge, and also empowering us and our colleagues in the Pacific to look after our women better. And we hope and pray that we use the knowledge we have attained to further reach out and help our women in the Pacific. In Jesus' name we pray. Amen.
Amen.
Thank you,
Thank
Tapa.
you very much.
Thank you, Emma.
Thank you.
Thank you, everybody.
Thank you, Betty.
Thank you.
Bye.
Bye.
Bye-bye.